Good morning, everybody. Today we will be talking on high flow nasal cannula. Last time we had talked on CPAP. So we all know that HHHFNC stands for humidified, heated, high flow nasal cannula. So each word on this is important, and we will talk about its importance in a while. Now, whenever you want to fix heated, humidified, high flow nasal cannula, you need to have cannula of different sizes, their tubings, the gas source, the blender, humidifier, and the oxygen tubings. So you should get everything ready. And the blender is the most important part of it because we cannot give 100% oxygen to any of our babies. And the nurse is an important role to fix this cannula, and once she is fixing the cannula, you can see that how easy and nice and neat and baby friendly it looks like. So baby looks quite happy on it. And let's go to the science part of it, that what do you mean by this heated and humidified high flow nasal cannula? So you are applying a heated and humidified medical air or an air and oxygen mixture, and this is being given through the nasal crowns. And what are the high flow rates? Anything which is more than 1 liters per minute, according to the Cochrane review, is called high flow. And usually all the clinical trials, they have used rates between 2 to 8 liters per minute. Now, how does it work? So the hypothesis is that there is a constant gas flow which produces a continuous descending pressure comparable to the conventional CPAP pressure. Now, how much this pressure is going to be delivered to the baby would depend on what's the flow rate of the gas, what is the diameter of the cannula, what is the size and weight of the baby, and how is the individual anatomy of the upper airways. So what is the fundamental difference between the HHFNC and CPAP? We all talked about it last time, that effective CPAP would require a good seal, a minimal leak, or a pressure transmission. However, a HHFNC, there requires a leak, and it is mandatory between the cannula and the nares, and the leak should be around 50 to 70%. So presence of leak is must. Now, what are the mechanism of action? We have all the problems when we talk about the babies as compared to pediatric and adults, but this is a place where we can take an advantage that the anatomical dead space comparatively the ratio is 3 times greater than in the adults if you compare, and this helps the mechanism of HHFNC to work better in our newborns. How? Because this nasopharynx over here, it's quite a big amount of dead space here, and this place works like a ventilation now. So we are ventilating our babies on the nasopharynx level, and the gush of air, when it is going inside, it's pushing out the carbon dioxide outside. So it's ventilating at the nasopharyngeal level, and hence the carbon dioxide washout occurs in the nasopharynx. Also, when we are giving in air inside the upper airway, the inspiratory resistance would reduce, the work of breathing would reduce, and because it is heated and it is humidified, it minimizes the metabolic work of the gas conditioning, and it improves the respiratory conductance and pulmonary compliance. So, does it really deliver the adequate pressures up to the distal airways? This is the question. And the basic investigations done by Spence et al. In 2007, where they looked into the high flow nasal cannula, is it providing pressures in the infants or not? So it was an observational study where they compared the HHFNC to CPAP, and they were correlating the gas flow with the intrapharyngeal pressure. What they found in the CPAP, if we are putting a CPAP of 2, it's delivering 2 of pressure. If we are putting 4, it's giving 4, and 6 if the mouth is closed. And what happens when we give high flow? So if we are giving a flow of 1, hardly any pressure, 2, hardly any pressure. Only when we reach 3, some pressure generates, and more than 3, there is a generation of pressure. That's what was seen. And so it was found out that there is a quasi-linear relationship between the airflow and the intrapharyngeal pressure. Now, another study done in 2008 by Wilkinson et al., they also did a observational study where they looked into the pressure generation and an effect by increasing the gas flow, and they used esophageal manometry to look at the pressure. And they found that if the flow was 2 liters per minute, hardly any pressure was being generated. Once it increased by 2 more and flow was 4, the pressure generated started and gave a pressure of around 4, and at 6 it gave a pressure of around 6. So that was quite encouraging results. And what happens if the mouth is closed or mouth is open? The diamond is the mouth closed, open, and the circle is the mouth closed, and we see it's much more reliable pressure generated if the mouth is open. So we don't need a real proper C. Another study done by Saslow et al. In 2006 looked into work of breathing and compared it to the work of breathing by the CPAP. And it was again an observational study which used a respiratory inductance plethysmography, face mask pneumatography, and esophageal manometry. And what they found was, again with pressure flow of 4 only, the pressure generation was better and comparable to the CPAP. And if we looked at the work of breathing, they were almost similar to the CPAP. So they concluded that work of breathing and the pharyngeal pressure are comparable between CPAP and high flow nasectomy. So what are the clinical evidences? We will never start doing something if we don't have an evidence. So let's look at that. So I will be talking on the clinical evidence at 3 places where we can use HHFNC. 1, used in post-extubation when we are extubating our babies. Secondly would be as a primary mode, and third is a weaning mode of CPAP. So, and we look at the evidence on those. So post-extubation, 60%, 2% of the UK units were using in 2015, 62% of Australia, and 26% of Japanese units were using it as a mode of post-extubation. So the Cochrane looked into this and looked into all the studies which had used as a post-extubation, and there were lots of studies. And if you see these studies, the flow was, in some of the studies were like quite in extreme, like very low flow in Campbell study in 2006. However, the other studies, they were all between 4 to 8. And China study, they did not even talk about how much they were using as usual. And Iran, they used flow of 6. So, and then the studies were like whether the antenatal steroids were given in them or not. So that was between 70 to 89%. And what was their failure criteria, whether they were put on CPAP, or they were intubated, or they were put on non-invasive ventilation. So they were different by the different studies. So when they combined all these studies, and Cochrane tried to look into treatment failure less than 7 days, comparing this from the CPAP, and on the left side is the high flow being a better result, and right side is CPAP as a better result. And it was seen that in less than 28 weeks, CPAP had a better result, though not really as it crossing the midline. And 28 to 31 weeks also there was no effect, and nor was any effect on more than 32 weeks. Overall, the treatment failure remained similar to in both the group CPAP as well as high flow. And then how many of them required intubation? So if you look at the babies who were less than 28 weeks, this timing is more towards high flow, because when the high flow was failing, they were put on the CPAP. So, and when the CPAP was failing, they were intubated. So definitely it will be looking like this. Still, it did not cross, really became very significant as it's crossing the midline. And the effect was also not there in 28 to 32 weeks or more than 32 weeks. And overall, it didn't have a difference. And pneumothorax, of course, was less in a hypronasal cannula group as compared to CPAP. There was no difference in depth or BPD between the two groups. The nasal trauma was much less in the hypronasal group. So this is a very good thing. And the other important outcomes were IVH, neck. They were not different. So conclusion was use of a high flow nasal cannula as a post-extubation support results is similar in sense treatment failure, intubation compared to CPAP. There were not much increase in BPD or death, rather there was a reduction in the pneumothorax. And I would say that subgroup differences are very important and they should be seen. So we can use either of the two in extubation. Now, high flow to wean from the CPAP in preterm infants. So who all are using it? Weaning from CPAP, it's being used in 38% of the UK units, 57% of the Japanese NICUs. So weaning RCTs were like by Abel Hadi, Patsy, Tang, and Sunswat. And they were using a flow between 2 to 6, very low flow, so by Abdul Hadi and Bodhi. So what they saw was that the use of CPAP was reduced in Abdul Hadi 7.6 versus 11.2 days, in Tang 1 versus 24 days, and Barry and Sunsawat did not actually report. Non-invasive ventilation duration was increased in Abdul Hadi, median was 18 versus 10.5 days. It unchanged in Badi, Tang, and Sonswat. It was similar. Then oxygen duration was increased in Abdul Hadi, 14 versus 5 days, reduced in Badi, 20 versus 40.6 days, and they were not reported in Tang and Sonswat. So there's a lot of heterogeneity. They were very small studies, and they were heterogeneous, and it shows that it does reduce the CPAP exposure. However, the non-invasive total duration did not change. And Melbourne opinion was that we don't consider it as weaning of CPAP. We are considering it as an alternative to CPAP. Then to use as a primary support in preterm infants. So who all are using as a primary support in preterm infants? Usually the UK units, they are talking more about it. Some of the US units and very few of the Australian units are using, and only one Japanese unit is used. What does the evidence say? So the Cochrane analysis was done, and it showed that further adequately powered randomized controlled trials should be undertaken. So there were lots of studies which were included. It's the first study used a very low flow, which is really not going to be effective. And the later, all the studies have used a good 4 to 6 and 4 to 8 flow. Out of these studies, I would like to talk on the Hipster trial, which was a very large trial and had to be stopped in between because of the failure in the HHFNC group. And another trial from India, from my friend Monika, also had to be stopped in between because of the higher failure rate in the HHFNC group. And these two had a similar kind of babies, 28 to 37 weeks. And if you see, none of the babies are less than 28 weeks. All of them are doing trials on more than bigger babies. And still there is kind of a failure. The latest trial is Hunter trial by Australia. So I will talk more on that because it's the latest one and is took more than 31 weeks and more than 1200 grams, less than 24 hours of age. When you, why we will take it separate? Because it's not combined in the meta-analysis because it was done later on. Rest all these studies were combined and their antenatal steroid use was quite different, ranging from 26 to 86%, and mean gestation was almost similar. The escalation was different. Some of them were actually putting them to CPAP, like Hipster trial and the Hunter trial, and some of them were actually intubating or putting them on non-invasive ventilation. In Monika study, they were putting on the CPAP and only some of them were intubating. So the Hunter trial, the population was preterm and the term infants requiring primary non-invasive ventilation, and but they were very big babies. And intervention was high flow nasal group 6 to 8 liters per minute, comparing with CPAP of 6 to 8. Outcome was treatment failure. And they found still, when they were using on a bigger children, they found the treatment failure to be quite higher in the NNH group, 21% as compared to 10%. Intubation was similar and liquid transfer was similar. So if we combine all these studies, barring this Hunter trial, it is seen that the treatment failure was much more in 28 to 31 weeker, more than 32 weeker, and even less than 37 weeker. Overall, the treatment failure was quite high in the HHFNC group and was favoring CPAP. And the percentage of the treatment failure, if we see 13% and 7% in 32 weeker and 9% overall. The requirement of intubation was similar, and the reason could be because when HHFNC was failing, it was going to CPAP group. So that's why it's more intubation were done in the CPAP failure group. Pneumothorax was less in the HHFNC group, but it was not statistically significant. It was crossing the midline. CI were also more than 1. And primary support, duration of support was like median days were different. Like in Sheen, it was 3 versus 2. Nevazari, 4 versus 4, and Hipster, 4 versus 3. But Hunter trial showed 20 hours versus 15 hours. So that was more, and that was statistically significant. So to conclude with all these studies, that we cannot have HHFNC as a primary support, more so in the smaller babies, even not in a very distressed bigger babies, because they have a higher rates of treatment failure compared with CPAP. Intubation is not increased with HHFNC because the rescue strategy is different. As I said, from HHFNC failure, they will go to CPAP, and then CPAP failure will go to intubation. And adverse outcomes such as pneumothorax, BPD, or death are not increased. Predicting success is probably not as simple as looking at gestation alone. Now, what our nurses say, because they are the ones who are taking care of these babies, the dark gray is strongly agreed, light gray is somewhat agree, and white is totally disagree, and black is don't know. So if you see the easier to set up and use, they are actually somewhat agreeing and strongly agreeing. More comfortable for infants, they are very strongly agreeing, 80%. Causes less trauma, they are strongly agreeing and somewhat agreeing. Patients prefer, they are strongly agreeing, and about the feed intolerance, they don't know much. So consensus is that high flow is equivalent to neonatal CPAP in case of safety, in case of efficacy, less trauma, less pneumothorax, no clinical significant adverse effects, more acceptable to the NICU nurses, to the family, to the babies, and it actually simplifies the care which we give to our babies by the caregiver. What are the practical considerations? Like, as you say, indication is post-activation. Primary mode, I would not say. Slow weaning on CPAP, some of them may use. If we haven't seen a nasal trauma on the CPAP, definitely we should go for this. And apnea of prematurity. So primary mode, I said, still vigorous clinicals. Why? When we should not use it? When baby is apneic, when baby has upper airway abnormality, and when baby is hemodynamically not stable. What are the key mechanisms? It's two mechanisms are there: humidity and adequate flow. Absolute humidity should be 44 milligram per liter and relative humidity 100%. So when humidity is very important, when we are giving proper humidity, absolute humidity, and all the time the maximum clearance is going to happen. If we are giving for some time, the maximum clearance is going to reduce. If you are not giving much properly and we continue to give it less, then thick mucus is going to be formed. And if we are going further down and going it less for a more time, clearance would be stopped. And then the cilia would be stopped, and then the cell damage would happen. So if we are exposing them with the lesser humidity for a longer time, we're going to damage the cells. So the optimal humidity is causing mucociliary clearance and giving comfort to the baby. The flow is giving an accurate oxygen delivery. It's washing out the anatomical dead space, and it might give some pressure as well. So what flow would we start? The flow should be such that it should be decreasing the work of breathing and delivering some distending pressure. So to begin with, between 1 to 1.9, we'll give 3 liters. Below that is no value. I told you the physiological part of it. 2 to 2.9, 4 liters, and more than 3, 5 liters. And you can increase flow by 1 to 2 liters after about starting the flow rate. However, having said that, when you set at 3, still these preterms may require actually more flow because the ratio of the dead space to the lung volume is quite high. And so they may require a higher flow rate. Don't forget that. So as I said, don't have picophobia. You may have to require higher peak going up to 8, 10. So is don't give flow phobia. And when to increase the flow. So whenever your baby is in distress, or your FIO requirement is increased by 10%, or your X-ray is showing less volume, or when you do a blood gas, the CO2 is seen to be increased, you have to increase the flow. When you decrease the flow, when clinically baby looks fine, when you have come down on your FIO requirement, when your blood gas is showing acceptable CO2s, you can decrease. How do you fit the cannula? So as you see, very, very nice open nares. Don't close the nares, leave up to 1/3 of the nostril patent. Please don't close, occlude the nostril. You may have a different kind of machines. This is a vapotherm, and this is like a Fisher and Becker. If you have this, you don't need anything more. You should have this pressure adjusting wall. And this is our OT. And if you have a Fisher and Becker, which all of our units have it because we are using CPAP, then just make sure that pressure relief valve is there and it is set to 45 centimeter of water. And just you need a blender and RT329 circuit and cannula of the 4 sizes. So this is a Fisher and Becker, and you can use OptiFlow. You cannot use a Rams cannula for this. Rams cannula can be used for CPAP, can be used for HHF, for NIPPV, but not for the HHFNC. And even normal oxygen cannula cannot be used for the HHFNC. So use the proper cannula. OptiFlow is a good and a nice one. So you may have more. And you can actually have color coding to select the size. So preterms, they have red, and it's for less than 2 kg, and you can give maximum flow of 8. The term is yellow, 1 to 8 kg, and 8 liters maximum can be given. Infant size is 3 to 15 kg, and is purple, and 20 liters can be given. And pediatric size is green, 12 to 22 kg, 25 liters per minute. Having said that, when you're newborns, you have a baby for a very long time in your unit, and it's more than 1 month, 2 months, then you can actually treat him like an infant. You can go higher on the floor. So this is the Comfort Soft Plus. So you can use either of the two. And but all of the infants cannot be supported with nasal CPAP or HHFNC alone. So we all know that 50 to 60% of infants fail CPAP as the initial form of support, as seen by Morley 2008 and the support trial 2010. And Safari in 2003 said that 25 to 38% of the infants failed CPAP following insured. And we should know the fail criteria is that if pH is less than 7.2, support oxygen is less than 50, FI2 requirement is more than 50, and PCO2 is going beyond 65. We have apneas, we have requiring a manual resuscitation, we have increased work of breathing, that's primarily safe. We are failing on either CPAP or HHFNC. So to end, we should know that we might have babies who may require straightaway invasive respiratory support. These are the bad infants. And we might have a baby who are very nice, good ones, which you can know that CPAP can help. And there could be a marginal babies where early CPAP failure can happen. So we have to look into these marginal babies. Thank you for patient hearing. And my next talk, we will go for NIPPV in a short time.